Slightly different track. So I'm going to put on my electrophysiology hat now. I have 3 hats, as you know, and I'm going to talk about anticoagulation. So I think anticoagulation is something that's very important. It's something that we are now standard of care, is bread and butter for us. And I think one of the things we have is that we are seeing a really remarkable increase in atrial fibrillation. So when you look at the Gulf Safe registry, which was a very nice registry, and actually I think many of the principal investigators are here in the room, not only do we have a higher increase, there's an increased prevalence of atrial fibrillation, there's also an increased prevalence of the risk factors. And in fact, even younger patients have really high CHA2DS2-VASc scores here, with a higher risk of stroke and higher risk of mortality than predicted by their age. So comorbidities are playing a big role here. So the DOACs have changed how we treat, as you know, stroke prevention. So now we have 4 studies, edoxaban and the ENGAGE study being the most recent, and that's 2013, that's almost 10 years now, but we also have ROCKET, AFib, RELY, and Aristotle. Now there are unique differences in the mechanism of action and the pharmacology of these agents. Just to focus on edoxaban today, edoxaban is a direct factor 10 inhibitor. The study included 21,000 patients. They followed patients for 2.8 years. It's actually the longest of all of the DOAC studies. The CHA2DS2-VASc score was high, it was 2.8. It was certainly higher than the RELY study and certainly higher than the Aristotle study with apixaban. And they had actually the best time in therapeutic range, which I think is remarkable at 68% over 2.8 years. To keep warfarin that tight for that long is really almost unheard of in any of the clinical studies, and certainly not in clinical practice. And they had a good, risk profile, including a HAS-BET score of over 50. So larger, longer, and better, well-controlled warfarin arm. I think this is a thing that they have a big advantage. So they included also a lot of subgroups, which is very important because this covers patients that were not seen in the other studies, and also, most importantly, patients that you're going to see in your clinical practice. So about a half had a CHA2DS2-VASc score over 3, and the other half had a CHA2DS2-VASc score of over 2. There are many of these patients had a creatinine clearance less than 95, and about a half also had been previously on warfarin. Many of them hypertensive, elderly was well represented, diabetics about a third, and prior stroke or TIA, which brings the CHA2DS2-VASc score up by 2 right away, is very significant. About 20% of these patients had a low creatinine clearance and a low body weight. So it really represents very well the frail, the elderly, the sicker patients, and really gives you a lot of randomized evidence-based towards how the treatment. So when you look at the overall study, and these studies are designed very similarly, the outcome of stroke and systemic embolism was significantly reduced by 21%, and hemorrhagic stroke, as you expect from all the DOACs, was again a very robust 50% reduction. But I want you to look at the actual number. Out of 21,000 patients, there were only 40 patients with a hemorrhagic stroke. That's a really small number in terms of absolute events. And that really highlights how safe these agents are, in particular in the high-risk patients that are enrolled in the study. So whether the patients had a CHA2DS2-VASc score above 3 or below 3, whether they were hypertensive, elderly, diabetic, all of them had a benefit compared to extremely well-controlled warfarin. I think this is something that's really very valuable when you talk about the safety in these studies. Now, when you look at the NOACs, and this is a study comparing the ROCKET, RELY, Aristotle, and ENGAGE, there is no difference really in terms of the reduction of stroke and systemic embolism, except in the RELY study with high-dose dabigatran. That is the 110, 150 milligram. Overall, NOACs are better than warfarin, well-controlled in stroke and systemic embolism. Now, the only once-a-day NOAC that is actually superior to well-controlled warfarin in reducing the risk of major bleeding, right? Comparing this to rivaroxaban, for example, there's a 20% reduction of the overall major bleeding event. And also when you look at the serious ones, because bleeding is bleeding, I understand, but a nosebleed is not the same as an intracranial bleed, and a nosebleed and a GI bleed are not the same either, right? So if you look at life-threatening bleeding, which has a very specific ISTH definition, intracranial bleeding and fatal bleeding, these are the ones that are most serious. There's about a 50 to 49% reduction. So this is extremely helpful in terms of the safety outcome. And I realize that the life-threatening bleeding is the one that we're always terrified about. The total number in the study out of 21,000 patients is only 62 patients. This is an absolutely tiny number considering the kind of patients that were enrolled here. Now, as you know, this is a therapy that's given once a day. And all of the specifically enrolled subgroups had a significantly improved reduction compared to well-controlled warfarin. Now, when it comes to safety, we have seen publications that show differences in outcome. I think this is something we really have to be very cognizant of. So you have to make a specific selection based on your patients, based on the safety outcome as well. So if you look at the RELY and the ROCKET AF study, it seems to be neutral in terms of the all annual bleeding events. It's basically the same on the line of identity. But with the ENGAGE study, we had a 20% reduction of compared to well-controlled warfarin in terms of the all overall annual bleeding rate as well. And the combined hazard effects basically favors NOACs in general. Gastrointestinal safety, if you look at the two specific NOACs with the most favorable major GI bleeding are here towards the right, basically left, which means that they're safer than well-controlled warfarin, whereas rivaroxaban and dabigatran had an increase in GI bleeding as well. So stroke and systemic embolism. Now, if you have a patient on edoxaban, there is a specific reason to reduce. You will give the 60 milligrams to everybody except those patients with one of the following: renal impairment, low body weight, or PGP use like verapamil, which is uncommon now, and dronedarone. So you only reduce the dose if you have one of the following, unlike apixaban where you have to have two. So it's a fairly simple dose reduction scheme. Now, those patients, excuse me, who had the reduction appropriately to 30 milligrams actually had proven reduction in the stroke and systemic embolism. So you don't actually lose any efficacy by reducing to 30 milligrams when that reduction is appropriate and based on the guidelines listed on the slide here. Now, major bleeding, as I mentioned, those patients who had a higher risk of major bleeding are whom? Those patients with a creatinine clearance between 30 and 50, low body weight less than 60, or concomitant PGP use, which is verapamil or dronedarone primarily. In that case, when you decrease the dose to 30 milligrams, you get a 37% reduction of major bleeding. So appropriate dose reduction, not inappropriate dose reduction, because we've seen, unfortunately, the clinical practice with many of our colleagues is to use the lower dose of apixaban, and this has been published from regional and international guidelines. That's not appropriate. Reducing the dose when it's not indicated only increases the risk and does not improve safety whatsoever. Compared to well-controlled warfarin, and this is something unique to this study, there was a 14% statistically significant reduction of cardiovascular mortality in the ENGAGE study during the long 2.8 years of the study as well. So we're getting a cardiovascular benefit that is well recorded in the literature. Now, what about type 2 diabetes and bleeding? Now, atrial fibrillation is more frequent in patients with type 2 diabetes. It's a major factor. And in addition, as you probably know, type 2 diabetes is also associated with increased risk of major bleeding. It goes up from 4.2 to 3%. So this is actually from the Gulf Safe study and some other local registries. So when we look at patients like this, diabetic patients were represented in 36% of the patients in the ENGAGE study out of the 21,000 patients enrolled. And, excuse me, the edoxaban was actually shown, again, once daily to be superior to warfarin, less major bleeding, and reduction of stroke and systemic embolism by 7% and safety by 21% in this same particular subgroup. In diabetic patients, the reduction of stroke and systemic embolism was actually more. It was actually 20%. And if you look at this hazard ratio for apixaban, actually apixaban starts to touch the line of identity. And in diabetics, there's actually an increased incidence of lower GI bleeding. I don't know if people are aware of that. Edoxaban at the 60 milligram or the 30 milligram dose. And here is the hazard effect for diabetic patients. Major bleeding significantly reduced compared to well-controlled warfarin in all of the clinical studies in the diabetic subgroup. So I think this is something that really has to resonate if you have a diabetic patient. What is the NOAC that is likely to reduce major bleeding, not just intracranial bleeding, which is a class effect compared to well-controlled warfarin? Now, what about elderly patients? It's also very clear that both stroke and bleeding increase as you get older. And of course, as we have more older patients with more atrial fibrillation, the risk significantly increase. There's an inflection point here around the age of 75. And in fact, the NOACs will give you greater safety benefit than one, warfarin, and certainly aspirin is no longer indicated. And also, number three, you can't not give them anything because you're concerned about bleeding. That's very dangerous too. So the elderly were represented very nicely in this study. 40% of the patients were actually above the age of 75, and this is a pre-specified analysis. And both major bleeding, intracranial hemorrhage, ischemic stroke, and stroke and systemic embolism, there was no modification. They were all significantly lower with a lower event rate in the elderly patients as well. So when you look at the net benefit, and net benefit is a nice word that's coined specifically for NOACs, or warfarin in general, and anticoagulation. In elderly patients with non-valvular AFib, there's a significant reduction, 36% of stroke and systemic embolism, and there's also a 23% reduction of major bleeding. So this is the significant reduction of both endpoints that actually gives you that benefit in the older patients. What about coronary artery disease? 4,500 patients in the ENGAGE study had coronary artery disease. This is a major overlap. Coronary artery disease is itself a risk factor, and these patients also need antiplatelet therapy. And here you see a significant reduction compared to well-controlled warfarin with the 60 milligrams in terms of stroke and systemic embolism, more reduction of ischemic events, and not affected by coronary artery disease. There was actually less bleeding than well-controlled warfarin with the standard 60 milligram dose. So if you look at the overall benefits of this therapy, it's actually once daily, reduces the risk of stroke and systemic embolism, as well as major bleeding, as well as myocardial infarction. This is the edoxaban line here in the lower corner. So 31% in MI, 19% in major bleeding, and 35% in stroke or systemic embolism. Now, the persistence and adherence is something that's subject to a lot of discussion. I think it's very important to remember that, excuse me, this is a study on practical utilization. It's fairly recent in German patients from 2023. Discontinuation rates compared to, adherence, compared to apixaban, dabigatran, and warfarin, much likely to continue to adhere, almost twofold compared to dabigatran, almost 60% higher with apixaban, and certainly 2 times more than warfarin. So since it is once a day, the adherence is likely to be better than any twice-a-day medication, and in fact, the efficacy appears to be maintained. Now, comparing this issue of twice-daily dosing NOACs and once-daily dosing NOACs, this was actually studied by a group of researchers in 2016. And one of the important points is this: the hazard ratio of stroke is similar if you have suboptimal adherence. So if you don't take your twice-daily NOAC, or you don't take your once-daily NOAC, your likelihood of having a stroke is higher. However, the number of patients who are going to be less adherent with a once-daily is less. This is 27% versus 32%, which is significant. So I think in a logical situation of people who take a lot of medications, reducing the pill burden while still maximizing your safety and efficacy is exactly what we're looking for. And I think that was the last thing I have to say, and hopefully there's some time for some questions.
Excellent. Thank you very much.